So I'm going to be talking about behavioral health management in long COVID care. My name is Tyler Prestwood. I'm an MD PhD. I completed my MD and PhD here at Stanford. Um, from a research angle, I have had experience working on dengue virus. About 20 years ago, I started in the lab working on that and looking at immunopathogenesis there. And then during my PhD, worked on cancer immunotherapy and helped develop some new treatments that we're hoping will make it to the clinic one day. And then through my clinical rotations, got very interested in psychiatry and unanswered immune questions in psychiatry and how that connects with psychiatric disease, how the immune system plays into that. So I'll be kind of touching on some of the areas I'm particularly interested in, but I do have this talk pretty predominantly focused on the psychiatric experience of patients and what it's been like for me in helping manage the psychiatric ramifications of having long COVID. So I have no disclosures to mention. But so I work as both a clinician and then as an immunologist researcher. I work with PJ Utz and study generally the like post-infectious consequences and impact on psychiatric illness, as well as general immune dysfunction that happens after viral infections, and then also attach that to primary psychiatric illnesses as well. So for today's talk, I'll be focused on what the psychiatric spectrum is in long COVID and how to recognize those features, and then what kind of plays into that biologically as far as what we understand. And then, as I mentioned before, understanding the psychological impact of long COVID, the way that it plays out in people's lives, and then what the barriers are to obtaining mental health care. And then last, I'll review the evidence-based approaches to treating the psychiatric complications of long COVID. So for me, just generally, I've only seen really maybe a handful of patients long term with long COVID, but have done some short evaluations with people when there's a concern for psychiatric pathology. So looking broadly, this is a study from 2023 published in Frontiers that shows the overall prevalence of psychiatric diseases and symptoms, comparing long COVID to overall world prevalence. So on the right-hand side, it lists the world prevalence median p-value here of depression, anxiety, sleep disturbances, PTSD, and cognitive impairment. And as you can see, this is relatively low instance, but the criteria used to report these were quite stringent. But about 4% for most of these illnesses at any given time is the prevalence, and then down to 1% with cognitive impairment. However, when you compare to people with long COVID, in general, it's closer to 20% for all of these different pathologies, which is, I think, very, very important in thinking about the patient experience of having long COVID. And it's important to note that a lot of these illnesses are quite nonspecific, and they have overlapping symptoms with long COVID, including fatigue, cognitive dysfunction, attention issues, memory deficits, and then sleep disturbances, whether that's not being able to sleep or sleeping excessively. So a word about the pathogenesis in general of what's understood about anxiety and depression and how that compares to long COVID. There are a lot of diseases that I'm very interested in that have this low-grade inflammatory signature, which often includes TNF alpha, low-grade TNF alpha elevations in the periphery, as well as IL-6 and CRP. We don't really know what causes this, and it shows up in a lot of different diseases. But it's not the same thing as when somebody is in septic shock and has really high elevation of these parameters. It is a chronic low-grade level that just tends to be on the higher side. And we know that shows up in long COVID patients, it shows up in people with depression, shows up in people with severe mental illness, as well as many other metabolic diseases as well. And then in terms of what's known from big biological studies, one of the best predictors of whether or not somebody, or one of the best differentiators between people who have long COVID and people who get SARS-CoV-2 infections and recover are the levels of cortisol. And those are reduced typically in people with long COVID. In depression and anxiety, those are fluctuating and distinct from healthy controls, but it doesn't show the exact same correlation there. And then in terms of the more speculative side of this slide, there are mechanisms of neuroinflammation and microglial activation that are thought to maybe result in pathogenesis. And it's known that hippocampal neurogenesis is a problem in depression, and it's been speculated that too is an issue in long COVID. And that the results of this inflammation drive these differences in synaptic plasticity, the maintenance of synapses, particularly in the hippocampus, which is a very active area in the brain for neurogenesis in adults. And then the downstream effect of that is believed to be working through neurotransmitter differences. The changes in levels of dopamine, epinephrine, norepinephrine result in this pathogenesis and exist in a cycle. And then in terms of the screening tools that are important, probably most people are familiar with these, but just to review, using a PHQ-9 is a good way for general providers to identify if somebody has psychiatric needs related to depression. If somebody has, for like reference, if somebody has a score over a 12 or 15, that range, it might be a good reason to talk about getting psychiatric referrals or getting psychiatric care if somebody's open to it. And then similarly, doing suicide assessments is always very helpful. GAD-7 is an analogous tool that's used for anxiety, and same with PCL5 with PTSD. And then PROMIS-10 looks more globally at how people are kind of coping with and perceiving the impacts on quality of life that they may be dealing with. But important considerations here, again, a lot of psychiatry is very nonspecific. And so just thinking about the physical symptom overlap of all these conditions with the long COVID pathogenesis, the fatigue, brain fog, sleep disturbances, headaches, muscle aches, all can go with basically any of these illnesses, depending on how they're affecting an individual. And then a word about kind of how patients experience in seeking diagnoses and being kind of referred to mental health care and the way that that is done. There's a study showing that people with POTS who later receive a diagnosis of POTS prior to getting that diagnosis were told, almost 4 out of 5 were told that they had a primary psychiatric issue, when we know that POTS does have this major biologic component too, and also affects people's psychological health. But then after they have a diagnosis of POTS, they aren't told this as much. So I think it's an important thing to think about as a provider, like as people are coming through, do we believe that this person is suffering from a primary biologic illness? And if so, how do we frame that for them? And then to touch on specific quotes I've had from patients that have left me kind of, thinking a lot about these things that have stayed in my memory that have affected the way I've perceived people's experience with long COVID. One patient was telling me that, I'll just read the quote directly, "This thing is eaten into my mind. I have this sense that either I've lost the plot or everyone else has." And this is a person who was otherwise very healthy until they got COVID-19 and then had this huge change in their life. And it really took away a lot of their agency to be free in their life and to exist socially the way that they wanted to, divided relationships for them. And then another quote, "Long COVID is like being hunted by a monster," which again is from an adult who had gotten this kind of after living a very healthy life. And then this comes in and now it's factored into a lot of their social decisions, work decisions, their relationships. Then another one, just touching on the issues of identity and agency in general, to have control over one's life. I was asking, what's your understanding of what long COVID is? And I was thinking about it very biologically, as I do. They said it's more of a political or societal idea. I was victimized, lied to, and stolen from, and I've been kicked down into a prison. Which really spoke to me as, this is his life. And then the last was from a female patient, when we were talking about her seeking disability. She said, "I worry that other people don't think my symptoms are real, and then I worry that my symptoms aren't real." And I think all of these speak to that psychological impact that a lot of this is secondary, right? And I've also touched on the primary biologic impact, but I think it's really important to remember this is where people are often coming from. And then, as I mentioned before, there are both direct and indirect impacts on mental health of long COVID. And just to touch on the things that are believed to be the major determinants of happiness for people: economic security, social relationships, physical health, freedom to make life choices, generosity, social cohesion, and then trust in institutions and society. And I'd argue that for a lot of people with long COVID, all of these can be compromised depending on the person and how this has affected their life. So it makes a lot of sense that there would be, both direct and indirect impacts on mental health. So this slide kind of follows from all that. Why do people have trouble getting into psychiatric care? One of those things is the stigma about mental illness. This is generally an issue in psychiatry, but particularly with an invisible illness that is suddenly come in and taken away somebody's quality of life, this is a big factor. And often for people, this gets reinforced by their experiences in the medical system. And I think in general, as doctors, we tend to focus more on physical symptoms, more things that are measurable, so we can look at treatment responses, and that's, I think, very fair. But at the same time, I think sometimes the mental health component can be a bit not a major focus of things. And then, as I mentioned before, invalidation of people's experience trying to navigate the healthcare system, and then the resultant distrust in the medical establishment when people feel like their symptoms aren't taken seriously, or their mental health considerations aren't really an important consideration. So then to go through the evidence-based treatments, we know from various trials that for treating depression, anxiety primarily, SSRIs and SNRIs work very well, and generally are very well tolerated. In long COVID specifically, personally I've seen benefits beyond mood and anxiety with SSRIs and SNRIs, where people do have a pretty big improvement in quality of life and even physical symptoms. And then using modafinil can be very helpful for some people with fatigue. Other people have had no response. And then melatonin is also really helpful in sleep regulation. And then center column are different treatments that are more psychological based, therapy based, kind of CBT adapted treatments for fatigue with graded activity and scheduling and pacing. And then mindfulness based stress reduction, very important in general in mental health well-being. And then some kind of more exciting treatments over on the right that are novel and active sources of investigation, and I know used by the clinic here at Stanford as well, both the low-dose naltrexone and low-dose Abilify, but also starting to use TMS to treat brain fog, which has some promising early results. And then wanted to touch on this study I found very interesting. This was done a couple of years ago. It was given where people with long COVID were given SSRIs. So one of these four, so fluvoxamine, citalopram, escitalopram, or fluoxetine, all of which have a higher index of sigma-1 agonism, with the idea being that the anti-inflammatory elements of that sigma-1 agonism could be important in reversing some of the inflammatory components of long COVID. In this study, I thought it was very interesting how they framed with patients that they were not giving these medications to treat depression, but instead trying to treat the brain fog, overstimulation, or cognitive issues that come up in people with long COVID. And what they saw was about 2/3 of the people had a pretty strong response to SSRIs. And in general, I'd say I see a quite good response with SSRIs in my patients as well. And then just to wrap up, I think the mental health component of long COVID is really complex, that there's a fundamental biological basis for it. And I think that's an important thing to remind patients of. And then it's really important in our job as providers to validate patients' experiences and how their disease impacts various aspects of their lives. And then just want to end with like a hopeful message that for patients, we still really don't understand the neuropsychiatric effects of COVID and the long-term consequences of that, but there are treatments that help and more advances are coming, and getting mental health care is not an admission of failure or neglecting physical symptoms, but something to support people through really challenging experiences. And with that, I'll pass it on to Dr. Lazaro. Thanks for your attention.